Recording. So before into the session, I would like to inaugurate the program with the welcome video. Just allow me a moment, everyone.
Good morning and welcome to the ICA Karnataka chapter of IACTA, Indian Association of Cardiovascular Thoracic Surgeons, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Heart Care Foundation Symposium. Actually, a webinar. Today, 14 July 2024. I welcome you to this webinar on echocardiography for hemodynamic calculations, mostly focused on intensive care unit, I think so. And I would like to welcome Dr. Rajavardhan Rangappa and Dr. Shivkumar to this August webinar. Dr. Rajavardhan Rangappa is a consultant critical care physician in Manipal Hospital, Sarjapur, Bangalore, and he's very well known for his interest in echocardiography and expertise in the same subject. And I request Dr. Rajvardhan to introduce Shivkumar and then carry on from there onwards. Please post your questions at the end of the questions will be answered at the end of the session, and please post your questions on the chat box. Thank you so much.
Thank you, Melissa, for the invite. As you know, Dr. Kumar is a close friend of mine. He has done his DM critical care from St. John's and has done EDIC also. He's working as a consultant intensivist in NH. Okay. His keen areas of interest are mainly critical care echocardiography. And I think he'll be lucky that he has got the topic. And I think he's been giving this topic again and again because it's his core field of interest also. I'll let Dr. Kumar take over the desk.
Thank you, Dr. Rajvardhan. So I'll just share my screen. So can you see my slides?
Yes, we can see.
Yeah. Is my slide moving?
Yes, it is moving.
Yes. So very good morning to everybody who has joined us for the breakfast Sunday echo session. So I'll be talking about hemodynamic calculations using transthoracic echocardiography. So from an intensive care point of view, in today's discussion, all of my the calculations will be based on transthoracic cardiography and not the transesophageal echocardiography. So traditionally, measurement of intracardiac pressures was using invasive methods like the pulmonary artery catheter. We used to place the pulmonary artery catheter and take the measurements. But after the echo came, either transesophageal or transthoracic, so it was a reliable alternative for measurement of intracardiac pressures. So it is an easy method, and it's actually a non-invasive method for intracardiac measurements. And hemodynamic measurements becomes important, especially in patients with shock in the ICU or in special settings where patient is having a valvular heart disease, and also to assess the fluid status in the ICU. This is the overview of what I'll be talking about in the next 15-20 minutes, the measurements in the cardia. So you have the right atrium. So I'll be talking about how to measure the right atrial pressure, the right ventricular ejection fraction, the measurement of TAPC, right ventricular systolic pressure, PASP measurement. The left-sided pressures, you have the left atrial pressure, how to measure, and mainly the measurement of cardiac output, VTI, ejection fractions, left ventricular end diastolic pressure, and finally the IVC index. So we'll go in detail step by step in each of these measurements. So the volumetric measurements that I'll be talking about, just to have a brief overview: the stroke volume, the cardiac output, the RV and LV ejection fractions, the ventricular dP by dt. I'll come in a bit more detail in the next few slides. The pressure gradients, especially in a setting where there is stenotic lesions or regurgitant lesions, where we want to look at the pressure gradients across the valves, the peak gradients or the mean gradients, at how to measure the valve areas, especially in a patient where patient having stenosis, you want to measure the valve area, how to measure the valve area or a regurgitant valve area. Finally, the intracardiac pressures, as I mentioned, right ventricular pressures, left ventricular pressures, the pulmonary artery systolic pressures, and calculated measurements will be the systemic vascular resistance and the pulmonary vascular resistance. And finally, the IVC measurements, how to assess the fluid status using IVC. So before we actually go into the discussion, we just a basic overview, basic concepts of physics. Suppose we have a known orifice over here. We have blood is flowing across this orifice from here, and how to if you want to measure the flow rate across this orifice of the blood of the blood flowing across this orifice, it is given by the formula. The product of the surface, the area of this orifice into the flow velocity will give you the flow rate across this orifice. So suppose you want to measure blood flow rate across a particular area, you measure the flow velocity, and if you have the cross-sectional area, the product of both will give you the flow rate. So first measurement is measurement of velocity time integral. So velocity time integral is nothing but summation of instantaneous flow rates across a particular area where it is measured. So it is actually a distance that the blood travels in a particular time, and we use pulse wave Doppler for its measurement. And we use VTI, by the velocity time integral, and we trace the Doppler velocity signal, and the machine will give you a VTI number. So as you can see here in the image, so in this area, this is for example, if we are measuring blood flow velocity in this area, we use pulse wave Doppler, and you get this waveform called the VTI. VTI is basically the distance that the blood flows in during this particular time interval is given by VTI in centimeters. So this is to give what is shown here is VTI measurement using a transthoracic echo. You use pulse wave Doppler across area over here, and you get this kind of waveform where we trace this waveform, and the machine will give you the VTI number in centimeter. That is actually the stroke distance, or the velocity time integral is a summation of the velocity of blood flow across this time period. So what is the use of VTI? So from the VTI, we can measure the stroke volume. The stroke volume is nothing but the product of velocity time integral in centimeter into the cross-sectional area of the area where we measure the VTI. Suppose we assume that this is the iota, this is the LVOT. So this is the cross-sectional area of the LVOT, and we measure the VTI here. The product of VTI into the cross-sectional area will give you the stroke volume. So cross-sectional area is nothing but it is a circle. So the formula of area of circle is pi r square. If you know the radius, you put into the formula, you will get the cross-section area of this valvular area where we are going to measure the VTI. So from VTI, we can measure the stroke volume. So there are a few assumptions that we make when we calculate cardiac output from VTI. We assume that the blood flow is laminar. So across an area where we measure, the blood flow should be laminar. Suppose there is a lot of turbulence in the flow, there's stenotic lesion or regression lesion, then your VTI measurement will be wrong. So other important assumption is the measurement of VTI and the area where you measure the VTI are done at the same anatomical location. It's not that you measure blood flow velocity one point and you measure the VTI at other point. Both should be measured at the same anatomical location. It is always, you should take an average of many readings. At least 3 measurements should be average in normal sinus rhythm. If the patient is having atrial fibrillation, at least 8 to 10 VTI measurements should be taken, a mean of those measurements, to reduce the error. One important aspect of measurement of cardiac output in VTI is measurement of this cross-sectional area, where we measure the cross-sectional area. So it should be very accurate, because in the formula, as I told, it is pi r square. Small error in measurement of the radius or the diameter is going to cause a significant error in measurement of cardiac output. So these are the assumptions. So among all the assumptions, the most important assumption is with VTI, when we measure, the Doppler beam should be parallel to the blood flow beam to avoid underestimation of VTI. To give an example here, here is the direction of the echo beam. Here is the direction of the blood flow. Both should be parallel to each other. You can see that both should be parallel to each other. Suppose you have you're getting a wrong angle. So blood flow is in this direction and your echo probe is in this direction. You're getting this angle called theta, which is the Doppler angle. As you can see, if the Doppler angle normally should be 0. If the Doppler angle is 0, your error is going to be 0. But if your Doppler angle is significantly on the higher side, like 50 to 60%, you're going to have a significant error in the measurement of VTA. So this important aspect you should keep in mind, that your Doppler with the direction of blood flow should be parallel to your Doppler beam. So so we can calculate cardiac output from stroke volume. The stroke volume times the heart rate will give you the cardiac output. And from cardiac output, we can measure the cardiac index. The cardiac index is nothing but cardiac output divided by body surface area will give you the cardiac index. So we discussed about measurement of VTI, how to get stroke volume, and from stroke volume, how to calculate cardiac output and the cardiac index. So when we how to measure VTI. So this is the apical 5-chamber window. You can see the left ventricle, the LVOT area. So this is the aortic valve. So you have the left atrium, and this is the LVOT. So this is the Doppler beam and the pulse, the sampling volume over here. It should be at least about 5 mm proximal to the aortic valve. You can see that the aortic valve is somewhere here, just below the aortic valve, and towards the LV, you place the Doppler, the sampling volume. And we measure pulse wave Doppler, and you get the waveform. It's in the parietal long axis, you get the waveform, and then you calculate VTI. So you measure the VTI, and you get the waveform in the apical 5-chamber window. And the next step in assessment of cardiac output is measurement of LVOT diameter. So this is the parietal long axis window. So you have the left atrium, left ventricle. This is the LVOT. You can see over here, both these are the aortic valve that is fully open. So in the parietal long axis view, you get a good view of the LVOT. You freeze the image and you zoom the image so that you get a exact. We have a good view of the aortic valve. So the area where you're going to measure the LVOT, the diameter is just about 0.5 centimeter proximal to the aortic cusp. So you can see this caliper is shown. This is where the aortic valve is. Just about 0.5 centimeter proximal to it is where you going to measure the LVOT diameter. So you got the LVOT diameter, you have the VTA, you can calculate the cardiac output. So there are other areas where you can measure the cardiac output, especially in a transesophageal setting. We don't do this commonly in transthoracic setting, but most of the times you can calculate using RVOT area, you can get the stroke volume, same like LVOT area. The transmitral stroke volume can be used to measurement of cardiac output. The transaortic valve stroke volume can also be used to measure the cardiac output. But in a critical area setting, most commonly we use the LVOT area and LVOT VTA to calculate the cardiac output. So from the cardiac output, you can always deduce the systemic vascular resistance. The formula is nothing but SVR is mean arterial pressure, that minus CVP by cardiac output into 80 will give you the systemic vascular resistance. And similarly, you can calculate the pulmonary vascular resistance from mean pulmonary artery pressure minus pulmonary capillary wedge pressure by cardiac output will give you into 80 will give you the pulmonary vascular resistance. So we discussed about VTI, cardiac output. We calculated indices, measurement of SVR. So other important measurement is suppose you're suspecting a shunt in a patient, maybe a VSD
Is the connection lost?
Yes, sir, it seems like that.
So as we wait for Shiva to join back, I would like to repeat some of the important points. LVOT VTI is one of the important parameters which is measured using pulse wave Doppler. The sample volume is placed in the LVOT and the pulse wave Doppler spectral profile is seen on the monitor, that is the echocardiography machine screen, and then you freeze it and trace out the spectral Doppler and you will get the VTI, and the VTI times the LVOT cross-sectional area is equal to the stroke volume, and from stroke volume you can get the cardiac output and the cardiac index. The important points actually mentioned were that you may take about 3 to 5 values and make an average of that. And in patients who have atrial fibrillation, you have to take anywhere from 5 to 10 values and then make an average to get a reasonably accurate estimation of the VTI. And also the thing is, as already pointed out, the echo angle, that is the insinuation angle, what you call the angle made by the echo beam and the blood flow, should be parallel to each other. The angle should be close to 0. The greater the angle, higher is the level of error introduced. So we have to see that the angle is closer to 0 than greater than 20. Up to 20 is acceptable because the error is up to 6% if the angle is up to 20. So that's fine in clinical practice. Now, Shiva, are you back? And the other important issue is that wherever you're measuring the diameter of the LVOT, the sample volume should be placed at the same place so that the variation in the diameter because of the shape of the LVOT should not influence the calculations. Hence, we place the cursor of the pulse wave Doppler exactly at the same place where you measure the LVOT diameter. And also, we should understand that LVOT may not be circular in all patients. So if it is elliptical, there may be some error introduced. So these are some of the factors.
Dr. Kumar, you are there?
Shiva, did you join back? I can see the screen, but Rajwardhan, do you want to add anything till he joins?
Yes. LVOT VTI has already discussed. It has got a lot of uses. Can anybody sum up where else can we use LVOT VTI?
The audience have a different link, so you have to pick.
LVOT VTI per se is used in cardiac output also. Most importantly, in ICU, we can use VTI variation. Okay, that is if patient is hypovolemic, we can use VTI variation instead of PPV or SVV. We can use VTI variation also to detect fluid responsiveness. If it is more than 20%, indicating that patient is hypovolemic.
Okay. Mute. I unmuted. Yes, I'm back. Thank you.
Yeah. Okay. Then if you have a difficulty in tracing VTI variations, you can still take the peak LVOT velocities and check the fluctuations in them instead of VTI variation. And it's also part of continuity equation to measure the aortic valve area. Okay.
Shiva, are you back?
I am back, sir.
Can you please continue from the place you left?
Sorry for the Yes. Sorry for the technical glitch. So, what I was talking about measurement of shunt. So, the shunt formula is QP by QS, the ratio of blood flow from pulmonary to systemic ratio. So, we can calculate the shunt equation, the shunt percentage using the echo as well. So, the QP by QS, the blood flow to the pulmonary artery is the stroke volume across the pulmonary artery and divided by the stroke volume across the left side, the LVOT. So we will get stroke. We can measure VTA across the right ventricle and the left ventricle, and if we have a ratio, we can measure the shunt. We can measure the shunt fraction from the transthoracic echo measurements. Another important measurement we have spoke about VTI is estimation of ejection fraction, that is most commonly done in the intensive care setting. Ejection fraction is nothing but the ratio of stroke volume by end diastolic volume into 100. Most of the times we commonly use eyeballing method. We just look at the visually how the LV is doing. We don't want an exact number, whether LV is 20 or 25. Most of the times we just want to know whether it is mild, moderate, or severe LV dysfunction. Other modalities of estimation of EF is fractional shortening mode using M mode, the fractional area change, and Simpson's biplane method. So here you can see this is a echo of a patient. This is a partial short axis view. On the left-hand side, you can see that the patient is having a normal LV function. On the right-hand side, you can see that in the short axis view, visually, there is patient having severe LV dysfunction. So visual estimation is what we do most of the times. We don't estimate the ejection fraction accurately. If you want to estimate the ejection fraction if you want to in an accurate basis, we can use other methods like the fractional shortening, the M mode. In this partial long axis view, we use the M mode, and the EF is given by the difference between LV end diastolic diameter by LV end systolic diameter divided by LV end diastolic diameter into 100. It will give you the fractional shortening percentage from which you can calculate the ejection fraction. Again, in a similar way, fractional area change in a short axis view, change of area in a short axis view in end diastolic to end systolic, you can put in the formula and you can calculate the ejection fraction. All right. In a similar way, in a Simpson's biplane method, in the machine, you have the option to track track the endocardial border. You can trace the endocardial border in the end diastolic and end systolic view, and you can impute in the formula, and you can get the ejection fraction. So most of the times, if we use the visual method, whether the LV is mild, moderate, or severe LV dysfunction, that is what you're looking at in an intensive care setting. Other estimate of LV function is the dP by dt, that is the rate of pressure increase in the left ventricle during isovolumetric contraction. So in the LV, when the valves are closed, before the LV, the aortic valve is open, is the isovolumetric contraction. The rate of rise of pressure in the left ventricle is the dP by dt. So if you see the pressure trace of the LV, this is the pressure trace of the LV, the LA pressure trace, and you view this is over down over here. That is the MR, the Doppler profile of MR wave. So the dP by dt is nothing but the rate of rise of pressure in the left ventricle. So in the velocity, how quickly it changes from 1 meter per second to 3 meter per second in the waveform. If you impute, and we can calculate the normal dP by dt. Normal dP by dt is more than 1200 millimeter of mercury per second. If it is less than 1200, then there is evidence of some LV dysfunction. So the time interval between the rate of rise of pressure between 1 meter per second to 3 meter per second in the MR jet, from that we can calculate the dP by dt is an indicator of LV function. So, next we'll move on to other measurements. So we measure measurement of pressure gradients. So in the valves across the aortic valve or mitral valve, we need to measure the pressure gradients, especially in the setting of stenosis or as a valve replacement surgery. We have to measure the pressure gradients. The formula is from the Bernoulli equation, delta P, the pressure change between area 1 and area 2 over here. Suppose there is a stenotic lesion over here. So the delta P, the pressure gradient, is nothing given by 4 times the V2 square. The V2 velocity 2 is velocity at the distal location, is the Bernoulli equation from which we calculate the pressure gradient across stenosis. To give an example over here, if patient is having aortic stenosis, we use continuous wave Doppler across the aortic valve. You get the Doppler profile over here, and this is the pressure tracing of the same patient. We can get the mean gradient. So in the waveform, you get the peak gradient and the mean gradient. So to give an example over here, in the same patient, we use across the aortic valve, we use continuous wave Doppler. You get a Doppler profile over here. You trace the waveform. The machine will give you the peak gradient and the mean gradient. From the mean gradient and the peak gradient across the valve, we can make out whether the patient is having a severe aortic stenosis or patient is having a moderate or a very severe based on the gradients. The gradient is very high, you're going to have a very severe aortic stenosis. The gradient is somewhere in between 20 to 40. There are various cutoffs for each severity. You can impute whether a patient is having severe aortic stenosis or a mild aortic stenosis. Similarly, across the mitral valve, you can use the continuous wave Doppler. You can get the peak gradient, so you can get the mean gradient and the peak gradient. So use continuous wave Doppler across the mitral valve. If you want to measure the mitral valve gradient, you trace the Doppler profile, and the machine will give you the mean and the peak gradient. All right. So similarly, from the gradient values, you can deduce whether the patient is having a mild, moderate, or a severe stenosis. So similarly, like we did the aortic valve, the patient can have a mitral stenosis. You can measure the gradients and make out whether the patient having what severity the stenosis is. So we covered the gradients across the valve. Other important estimation is valve areas. So what we want to know is what is the diameter of the valve, especially in setting of stenosis. We use the continuity equation. So suppose blood is flowing from area 1 to area 2, and suppose there is a stenosis over here. So whatever the stroke volume that is coming from this area must be equal to the stroke volume that is coming over here. Stroke volume 1 will be equal to stroke volume 2. Suppose if we can measure VTI over here, and if we can measure VTI over area 2, we can if put in the formula, we can calculate the valve area. So I'll give you an example. So over here we have suppose we want to measure the aortic stenotic valve area. So this is the LVOT area over here. This is the LVOT area. This is the aortic valve area. So the stroke volume of the LVOT will be equal to the stroke volume across the aortic valve, because the same blood flows across the same area. So stroke volume is nothing but cross-sectional area of the LVOT into VTI. Similarly, across the aortic valve area into VTI. Aortic valve area into so if you want to measure the aortic valve area, you can, if you have the VTI across the both areas and the cross-section area of the LVOT, you can deduce the aortic valve area. That is a continuity equation which you can measure the mitral valve. We measure using the formula over here, the 220 divided by pressure half time. So this is the waveform across the mitral valve in continuous wave Doppler. The MR jet is over here. So the rate of so pressure half time is the time required for the peak gradient reduced by 50. So you can see over here, from the peak gradient to reduce by 50, what is the time required? So if you the machine will give you the time. If you know the time, so there's a method to measure the valve area in mitral stenosis. In our intensive care settings, we don't usually measure the valve areas, but these are few measurement principles that you should be aware of. So from the valve areas, we move on to measurement of intracardiac pressures that is commonly performed. So the measurement of right ventricular systolic pressure that is commonly done. So we use a measurement of the TR, the tricuspid jet velocity. We measure the jet velocity, and from the velocity of the jet, we measure the right ventricle systolic pressure. So because it jets high velocity, we use continuous wave Doppler, unlike the pulse wave Doppler that I spoke about before. We use the Bernoulli's equation, the concept to measure right ventricular systolic pressure. The formula for measurement of right ventricular systolic pressure in millimeter is 4 times the TR jet velocity you summated to right atrial pressure in millimeter mercury will give you the right ventricular systolic pressure. All right. So here in the patient, you have in the 4-chamber view, you can see that there's a blue jet over here that is a severe TR jet. You can see the blue jet jetting into the right atrium. So blood flows from right atrium to right ventricle, but there is a severe TR jet going into the right atrium. So that we use continuous wave Doppler. The Doppler signal is here, and we press continuous wave Doppler. You get a good waveform, that is continuous wave Doppler waveform of the TR jet. So we measure the TR jet velocity, and from that we impute the right ventricular systolic pressure. So right atrial pressure, how do we measure? So right atrial pressure can be imputed from the IVC diameter. So normally, if the IVC, you can use this table. It is available online. And so based on the IVC diameter, if it is less than 1.5 centimeter and is collapsible, the RA pressure is about 5 millimeter. So based on the diameter, if it dilated more than 2.5 centimeter and it's not collapsible, your estimated RA pressure is about 15 to 20 millimeter mercury. So you can add this RA pressure into the TR jet velocity, you will get the right ventricular systolic pressure. Most of the machines does the calculations on its own. If you put the values, so it will give you automatically the pulmonary systolic pressure. So you can also measure the pulmonary diastolic pressure that is given by the formula, the 4 times the pulmonary regurgitant jet velocity, end velocity. It's not the TR jet across the pulmonary valve. If you put continuous wave Doppler, you get pulmonary regurgitant jet velocity. The end jet velocity, if you input it to the formula, will give you the diastolic pressure measurement. Similarly, the mean pulmonary artery pressure can be imputed by the peak of the pulmonary regurgitant jet velocity into right atrial pressure, will give you the mean pulmonary artery pressure. But most of the times, if you want to measure right side pressures, right RVSP, you'll be imputing the right ventricular systolic pressure using the TR jet velocity. So how to measure the left atrial pressure? If you want to measure the left atrial pressure, the formula is nothing but systolic blood pressure minus pressure gradient across the mitral valve. So this is the apical 4-chamber window. You use continuous wave Doppler. You put continuous wave Doppler across the mitral valve. You get the mitral valve MR waveform, and the pressure gradient across the mitral valve. You get the peak gradient, and you put it in the formula. You'll be getting the left atrial pressure. Similarly, the left ventricular end diastolic pressure can be measured using the formula diastolic blood pressure minus 4 times the AR jet, the aortic across the aortic valve. We measure the aortic regurgitant jet velocity at the end, aortic regurgitant jet velocity over here. So this is the AR jet waveform. The end aortic regurgitant jet velocity will give you in the formula will give you the left ventricular end diastolic pressure measurements. So another important right ventricular pressure measurements is the TAPSE. So TAPSE stands for tricuspid annular plane systolic excursion. So in a vertical axis, how good the tricuspid annulus is moving. So with RV moves always in a vertical fashion. So every heartbeat, how big is the RV tricuspid annulus moving. So you get a good apical 4-chamber window across the tricuspid annulus. We use M mode, so you can see that the tricuspid, we measure the TAPSE. That is the normally TAPSE should be more than 16 millimeter. If your TAPSE is less than 16 mm, there is reduced TAPSE, means there is significant RV dysfunction. So other important measurement is IVC measurement. This is a subcostal view. You can see the IVC. So this is the IVC maximum diameter and the minimum diameter. You can use the M mode, impute the maximum diameter and the minimum diameter. So from the maximum minimum diameter, you can get the IVC index. In a patient on mechanical ventilation, this is the formula. IVC distance index is equal to maximum IVC diameter by minimum IVC diameter by the IVC minimum diameter. If it is more than 18%, the patient may be fluid responsive. It is an indicator of patient may be fluid responsive. So in a patient, spontaneously breathing patient, we use IVC collapsibility index. So the formula is IVC diameter maximum minus minimum by IVC maximum. If it is more than 50%, the patient is fluid responsive. So this is in a patient with mechanical ventilator on positive pressure. This is in a patient with spontaneously breathing patient. Other IVC index is called delta IVC. Delta IVC is nothing but IVC diameter maximum minus minimum by IVC mean into 100. So if your delta IVC is more than 12%, your patient may be fluid responsive. This is one of the IVC indices that you should be aware of: the IVC distribution index, the collapsibility index, and delta IVC. So to summarize what the cardiac measurements that I spoke about, so I discussed about velocity time integral measurement, how to measure the VTI, how to measure a VTI, how to calculate cardiac output from the VTI. So from the VTI, you get the stroke volume. From the stroke volume, you can calculate the cardiac output. So other important measurement is EF estimation. Most of the times we use eyeballing method. We want to know how the LV is doing, whether the LV is having severe LV dysfunction, whether there is a moderate LV dysfunction, whether there is a severe LV dysfunction. Other methods of LV estimation would be the fractional area change in M mode, the fractional in the short axis view. We can look at the fractional in the M fractional area change, and the Simpson's method can be used. The pressure gradients, especially in a patient with valvular abnormalities, using continuous wave Doppler across the valve, you measure the gradients, the peak gradient, the mean gradient. From the gradients, you can whether you can make out whether the patient having a severe stenotic lesion or a moderate or a mild lesion. Other important measurement is measurement of PASP. PASP, how we measure from the TR jet velocity. In the four chamber view, we measure the velocity of the TR jet. From the TR jet velocity, we measure the RVSP. From the RVSP, we can measure the pulmonary systolic pressure. Will tell you what is the severity of pulmonary hypertension in your patient. Other important RV assessment is TAPSE. In how we measure TAPSE is in the apical four chamber window. On the tricuspid annulus, we use M mode. We look at how the annulus is moving. The normal TAPSE is more than 16 mm, as I mentioned. If a TAPSE less than 16 mm indicates a RV dysfunction. IVC index. So IVC index is distance rate index. The collapse rate index, as I mentioned, it is an indicator to assess volume responses. It can be done. So the diastolic dysfunction assessment is a separate class altogether. I've not included a diastolic function assessment as a measurement of intracardiac. So what I covered is mainly the measurement of intracardiac pressures, estimation of cardiac output. That is important measurement, and measurement of intracardiac pressures, PA pressures, TAPSE, and the IVC index is what I've covered. So any doubts, any inputs from the audience, or any doubts, we can have a discussion. Any doubts from the moderator is also any inputs from the moderator, and we can have a discussion. So if you have any doubts in any particular slide, I can always go back.
Thanks, Dr. Shiva. Okay. It was a nice class. As you know, nowadays everybody does echo. How to differentiate yourself from others is understanding the dynamics behind it, understanding this calculation and all. That's how you can differentiate yourself from others, if you ask me. That is the main thing. And Shiva, can you tell me some of the clinical implications of these measurements? I know you talk about how to measure and all.
Yes. Yeah.
Example, example TAPSE per se or PSP. Okay,
Yeah.
how it is them in clinical implications of measuring these kind of things at the bedside?
Yeah. So clinical implications would be if we starting with VTI. As you mentioned, VTI can be used for what we look at. VTI variability can be used for assessment of volume responsiveness. If the change of VTI is more than a particular number, then you can help you decide. We can take a call of giving fluids to the patient. All right. And VTI is a number. If the VTI is very low, maybe the patient having a low cardiac output. The VTI is normal, then you're pretty sure that the patient is having a normal cardiac output. Other uses of other measurements, mainly the TAPSE and the PASP, is suppose you have a patient with the pulmonary hypertension, COPD patient, the copper patient. It gives you an idea of the severity of the pulmonary, especially in a cardiac surgical patient. We have a severity of the right-sided RV dysfunction. So we measure the pulmonary systolic pressures. We can have a regular measurement over the point of time and we can target specific therapies for RV dysfunction. And TAPSE is also an important aspect to assess RV dysfunctions. In a medical ICU, RV dysfunction mainly important clinical scenario would be patient with pulmonary embolism. So the patient is coming with shock. You're thinking of pulmonary embolism. You can do echo. You look at the TAPSE. TAPSE is RRV dilated. TAPSE is on the lower side. Your patient having severe RV dysfunction. The patient is not fit enough for a CTPA. Then the clinical scenario, it helps you make a decision of assessing the RV function, and a patient having a severe RV dysfunction. So those are the clinical scenarios where a measurement of TAPSE and pulmonary systolic pressure may be useful. IVC index mainly to decide on assessment of volume responsiveness, to give or not fluids for a particular patient in the ICU.
That's excellent, Shiva. The one more thing I want to highlight is, pulmonary pressures PSP will be high in both in acute and chronic conditions. It can be P or it can be pulmonary hypertension per se. How to differentiate at bedside is by using RV free wall thickness. If your RV free wall thickness is more than 5 mm, it might indicate that it's chronic. If you have to make an urgent decision at the bedside doing a thrombolysis or based on the clinical picture, so make sure that you measure RV free wall. If RV free wall thickness is quite high, it indicates that there's a RV hypertrophy and indicating that it's a condition is chronic. Okay. Okay. Any more questions? Any questions from the audience?
As of now, there are no comments or questions in the chat box.
Yes, one question I have received one question from the delegates. I'm putting it in the chat box.
Yeah, I just put it on the chat box. Thank you, Sridhar. That was a good presentation.
Thank you, sir.
Thank you so much. And also, maybe one word should be mentioned about pulmonary venous velocity profiles, because it comes into picture both in the evaluation of mitral regurgitation as well as diastolic dysfunction. In mitral regurgitation, the pulmonary venous Doppler contains 3 waves. Of them, S, D are positive waves and A wave is negative wave. So S is representing systole, ventricular systole, D represents ventricular diastole, A represents the atrial reversal. Because of the contraction of the atrium, some blood goes back to the pulmonary vein and produces a negative deflection on the pulmonary venous flow Doppler. So the variations in these waveforms can also indicate us about the disease states, especially useful in mitral regurgitation and diastolic dysfunction. Now we'll go on to the question, which is that pulmonary artery systolic pressure calculation in patients without TR. Very important question. Sridhar, can you answer that one?
In a patient without, suppose any patient, a normal patient will have some amount of TR. That is
Yes.
from without a TR, it is, as I am aware, I don't think we can measure the PASP.
You can measure by using acceleration time at the pulmonary artery. Okay, we can use the acceleration time. If its acceleration time is on the higher side, I'm not sure, 80 to 120 was the value. Okay, if it is more than that, it's indicating that pulmonary artery hypertension is there.
Yeah, that is true. It is called pulmonary acceleration time.
Yes.
The short form used is PAT, but it should not be confused with paroxysmal atrial tachycardia. It is pulmonary acceleration time. If you trace the pulse wave Doppler across the pulmonary valve or pulmonary artery, the time taken from the beginning of the upstroke to the peak of the upstroke, that is the time, that is the pulmonary acceleration time. And it is inversely related to the pulmonary artery pressure. Greater the pulmonary acceleration time, less is the pulmonary artery pressure, and vice versa. So you can calculate the pulmonary artery pressure indirectly using the pulmonary acceleration time, using a formula where you minus the pulmonary acceleration time from 92 and add multiplied with 0.6, you get the pulmonary artery mean pressure. And most often you use the pulmonary artery mean pressure when you define the pulmonary hypertension. Now the definition for pulmonary hypertension has been redefined as mean pulmonary artery pressure of 20 millimeters and above.
And the other thing is, when you look at this waveform also, in case of pulmonary hypertension, it will be dual waveform will be the notch pattern, they call it. Okay, that is one of the other way you can this thing. What you can do is you can also put a color Doppler into the pulmonary artery, which might show the flow reversal in the pulmonary artery. Okay, indicating a pulmonary hypertension. These are the indirect parameter by which you can say that there's a pulmonary hypertension. One is acceleration time, and other one is looking at the pulmonary artery waveform, which might be notched when you look at the waveform. Third is by putting a color at that point of time where it shows that there's a reversal of flow in the pulmonary artery.
Yeah. Any other questions are there? Any comments or questions?
Yes, sir.
Do you have any more questions?
Yes, sir. We have 3 questions, sir. Just a moment.
Can you please post it?
Definitely, sir.
Calculation of LVEDP in absence of AR. How do you calculate LVEDP in the absence of AR? The reply
Yes,
to this
out-
is LVEDP same as LAP, that is left atrial pressure if the
That's
mitral
just,
valve is normal. LVEDP same as left atrial pressure in the presence of normal mitral valve and normal compliance of the left ventricle. If you want to get the LVEDP in the absence of AR, you have to look at the systolic blood pressure, and the MR should be there. So you subtract that with the MR jet pressure gradient. If you subtract MR pressure gradient, that is the gradient between the LV and the LA during systole, if there's MR, you subtract this amount from the systolic arterial pressure, you get the left atrial pressure. Is that clear? Now we'll go to the next question. Can you please explain how to measure LVEDP in detail? Sivakumar, do you want to take
Yes,
that
sir.
one?
Yes, sir. Yes, sir.
LVEDP
So
in
LVDP, yeah. So
detail.
to
One
measure,
method I already described. In MR, you can determine the LAP by looking at the mitral regurgitation jet gradient. So mitral regurgitation jet gradient plus LAP will be equivalent to the systolic arterial blood pressure. So because you know the systolic arterial blood pressure and you know the jet gradient, MR jet gradient, if you subtract MR jet gradient with the systolic blood pressure, you will get the left atrial pressure.
Muralidhar,
Yes, madam.
can I say on this LVADP?
Absolutely. Please go ahead.
If there is no MR, many times there is no MR. So we
MR may not be there.
yes.
The one
So
method described was Dr. Sridhar was mentioning about AR.
No, I'm just trying to give you this LVDP if there is no AR. Sorry, AR.
Yes.
Yeah.
When there is no AR, then we have to take advantage of this A wave, E and A wave or reversal in pulmonary vein. If you calculate the duration of these two waves, because these are end diastolic phenomena.
Correct. Correct.
So if you take the difference of AMV and APV, and if it is more than 35, it gives you raised LVDP. It may not give
Right.
you
Right.
number,
That's another way to do it. Yes.
but
Yes.
it
Yes.
is, and it's very easy. And many times AR is not there. So
And also, yeah, thank you for that point. And also, if we take the E by E prime ratio,
that also
if it is more than 14, it indicates that the pulmonary artery bed pressure is greater than 15. And we think that pulmonary artery bed pressure is same as LAP and LAP is same as LVEDP. So indirectly, you can say that E by E prime also can be used. Do you agree with that, Sanjeevani?
yes, sir, absolutely. And another one point I just wanted to add or suggest is that M mode for LVEF is not recommended. Strongly not recommended by
yeah.
ASA.
Yes, okay.
ASE.
Because if we tend to see that, of course, because all machines have that measurement and that we can't take out that. So it is very easy.
Sure.
But this MAPSA is gaining kind of slight importance now in the context of sepsis, actually. They feel that it might affect longitudinal movement more than this thing, and it might predict. Generally, we know that LV systolic function may not affect the mortality. Now they're coming up studies where they're telling that MAPSA and global longitudinal strain might affect mortality more than your EF. So that's something which is upcoming thing. Not now at this point of time. Definitely in the future, it might have a role.
Yes. They used to say TAPSA is more reliable than MAPSA as a measure of respective ventricle function.
Yes, because
but maybe, what I have seen is MAPSA really, I'm doing this every day actually, and MAPSA really is quite high in spite of low EF. So I don't know, maybe I'm wrong.
No, you are right only. what I'm telling in sepsis, in the context
Yes,
of
yes,
sepsis,
sepsis, in condition of
yes,
sepsis.
in the
Yes,
context of sepsis, it might affect the patients who have less MAPSA
yes,
have a higher mortality compared to your EF percent. That's what they're
yes,
thinking at this
yes.
point of time.
Yes.
Maybe in the future it might have a role. Some studies, in the future we might see more studies to this aspect.
Yeah, in sepsis, the story is slightly different because there are two aspects. One is sepsis-induced cardiomyopathy or sepsis-induced myocardial depression. If it is myocardial depression, it is reversible and usually patients recover without any difficulty. So even if the LVEF is low, subsequently because they recover well, you get a reasonably good result in those patients. LVEF is decreased because of sepsis-induced myocardial depression.
Yes.
But if it is myopathy, it is a story slightly different. So there is slight difference between myopathy, sepsis-induced myopathy, and sepsis-induced myocardial depression. And the other question which is asked is MAPSA. How do you measure MAPSA?
So, yeah, TAPSE is across the similar
No,
way.
this is MAPSA, mitral
MAPSA.
annular plane systolic excursion. It is similar to TAPSA. You just do it on the left side, mitral annular systolic excursion, annular plane systolic excursion. You measure. It is similar to what you do for TAPSA on the right side. You just do it for the mitral valve on the left side. Sanjeevani, do you want to say anything on this?
No, MAPSA is correct. No issue about it. Actually, for LV dysfunction, MAPSA, MR, DPDT, then your LVOT-VTI, all these are very important in addition to EF and of course strain nowadays.
Yeah.
Another important thing which both this moderator and speaker have already told, but just wanted to highlight that please do LVOT-VTI in ICU. It's a very good indication, only LVOT-VTI. And not only fluid responsiveness, but also inotropic requirement. He has
Right.
already told, but I'm just reiterating because it is
easy to
simple.
do.
It is very simple and very
Easy to do.
effective.
Yes.
It is easy to do. Only thing is you have to do it at the same place all the
Same
time.
place, yes.
And also in the
Otherwise,
context,
echo is difficult in ICU setup, so this is very easy that way.
and one more thing, it has an important role in monitoring in ECMO patients, especially ECMO patients.
Yes. So very effective. But trend is important. Only one.
Yes.
That is very important.
Hmm,
And preferably only one person doing it. One machine, one person.
I think there are no further questions. I
No,
would like
sir.
to. I would like to thank both Sridhar and Rajvardhan for being present and Dr. Sanjeevani for a contribution. And before we conclude, I request Mamita to play the
Sure,
video
sir.
regarding the
Yes.
IACTA TE workshop in August. Please join us that time, and then you enjoy your Sunday.
Yes, sir. So shall I play it now, sir?
Yes.
Thank you, sir.
Thank you and goodbye. See you next
Thank you,
week.
sir. Thank you, sir.
Thank you. Thank you, sir.
Thank you
you,
so
sir.
much, sir. And thank you so much to all of you. And with all due permission, I'm closing the session here for today. And happy Sunday to all of you. Thank you.
Thank you very much.